Welcome to Care Team Conversation Podcast, sponsored by Curbell Medical, featuring clinical leader and fall prevention and patient safety awareness expert, Dr. Patricia Quigley. This episode, Dr. Quigley speaks with guest Dr. Amy Hester, nursing innovator and co-founder of HD Nursing.
Dear colleagues, we are so delighted to welcome you to this inaugural gathering and podcast. And as you hear my voice, this is Dr. Patricia Quigley, and I'm so excited to have this inaugural podcast be with Dr. Amy Hester, my colleague, my friend, who is so extraordinary as a nurse scientist and nurse informaticist. And all that she does as an entrepreneur to launch an incredible business called HD Nursing. We hope that you'll find this enjoying and enlightening, and we'll give you some ideas as you go forward, as you listen to the two of us who are absolutely dedicated to advancing knowledge, practice, and science surrounding fall and injury prevention. So with that, I think that it would be really nice, Amy, and I hope you don't mind if I call you Amy.
Right, please.
Patent Amy, that Amy, if you wouldn't mind just sharing with people a little bit about yourself and how you got interested in fall prevention, and then I'll share with the audience as well.
Yeah, absolutely. So I'm a nurse by background. I spent a good majority of my career at the University of Arkansas for Medical Sciences. It's our state's only academic medical center. I'm board certified in medical surgical nursing, and my clinical specialty is in the neurosciences. I really love that population. So I spent 26 years at UAMS before I retired in 2018 and came full-time over to HD Nursing. And so that's a little bit about me.
Well, I know that there's more about you than that because you're also an inventor. What got you interested in inventing and looking at doing things that are different?
Rewind back to 2006 when Joint Commission first had their national patient safety goal around falls with injury. And then right in that same time period around 2008, when falls were first defined as a hospital acquired condition, I was the manager of the neuroservice line at UAMS, and that patient population just historically has the highest rates of falls and falls with injury within acute care. And we were certainly experiencing that in the patients that we were serving. And we were getting all of these external incentives from payers and regulatory agencies to really address falls in a way that we hadn't done before. And what we quickly realized was that what was available for us for falls and injury management for the neuro population at the time really didn't meet our needs. It wasn't getting the job done, and we really needed to establish a better way to serve those patients more holistically to prevent falls and falls with injury. And so that was really the catalyst for what got us started in looking at falls and injury specifically. I never intended to be an inventor or an innovator or an entrepreneur. So that's where it started out. It started out that way, and everything else just kind of unfolded from there.
And has truly been extraordinary. I hope everybody really gets to learn more about you, not just while we're together for this podcast, but also learning more about you after this podcast. And Amy, I'd like to share with all of our audience too, the way I got into falls, because I've always wanted to be a nurse. I've been a nurse since I was 3 years old. That's all I ever wanted to do. But, when I actually became a nurse, and my very first job was on a stroke unit. And on that stroke unit in a public hospital that turned no one away, I worked with therapists. Before that, when I was a student, I actually did all of my preceptorships in public health. So it was very different being in a hospital and then working with therapists. And what I found on a stroke unit is that everyone I thought was really complacent about falls, that they accepted that falls were part of what happened in our care. And I just never was settled with that. I saw the fear that happened. I saw the injuries that happened. And that's what really got me started. And then I moved, of course, into rehab from being on a stroke unit. I moved into rehabilitation, setting up the very first rehab unit at this hospital, Bayfront Medical Center. But I just did not accept that falls was inevitable for people who were newly disabled or living with chronic diseases. And you know what? I never gave up. There were lots of times over my many years of nursing that, people would say, oh, this is not preventable. This was just part of what was going to happen. And I just never accepted that. So as I continued my journey in fall and fall injury prevention, we started launching more work in this area. Some nurse scientists got together at the Tampa VA. We referred to this as an orphan issue, that falls was an orphan issue where everybody else gave up on it and just allowed it to continue to happen without really thinking about how they could drill down and prevent it. And that's how I really connected with you. And I like to just share with the entire audience what I was so impressed about in being able to work with you, Amy, is your commitment to really moving towards appreciating that there are things that can be done to be able to mitigate and eliminate fall risk factors. And that was always my goal. That was always my heartbeat, as I know is a shared heartbeat with you. So that was my interest. And I know that we're so committed to making sure that we do everything we can, that if a fall does happen, that people learn from it, but we're going to really change the world so that we move everybody away from looking at falls as something that's inevitable and is going to happen in our care, or even worse, blaming patients that falls are happening because they're not doing the things that we suggest that they should be doing. So let's all work together, colleagues who are listening to this podcast, to learn really from Amy and I as we move forward a little bit more into what you can do as well. Amy, let's talk a little bit about what is the difference between fall risk screening versus assessment?
So that's a good question, and it's a question that we get a lot. Most people are using fall risk screening tools, and those are tools that have been around for a very long time. Morse Fall Scale is a perfect example of that, the Conley, the Schmid, Johns Hopkins. If you look at those are going to give you a yes, no, your patient's at risk, and some of them may even give you cut scores to stratify degrees of risk, like low, moderate, high. Most screening tools give you a single cut score, and when a patient reaches that threshold, they're determined to be at risk. An assessment tool goes much deeper than that. An assessment tool is going to do deeper dives into the questions and more of them that will look at what it is that's creating fall risk in that individual. So it's not just yes, no, my patient's at risk. It's also the degree of that risk, but more importantly, the why that person is at risk. And that why is really important. If you don't know the why, you can't get to individualized medicine. You can't get to precision in care. So if you're using a screening tool that gives you a yes, no, that's the starting point. You have to go into deeper assessment questions after that. Once you get that, yes, your patient is at risk. And that's where a lot of people stop. They stop, yes, my patient's at risk. I use universal fall precautions, and we all know those don't work. So that's really the core key differences between assessment and screening that I would say.
And I just hope that people really hear this as they get to listen to your explanation, because I agree too. Having worked predominantly with the Morse Fall Scale and throughout the Department of Veterans Affairs, we knew years ago, back even in 2001, and this is 2022, that the Morse scale was only a screening scale. It was only yes, no questions. And Dr. Morse always said that it was a positive screen, which would be the driver for assessment. But for some reason, organizations just did not understand that. They didn't understand the tool, and they took that forward literally as an assessment tool. And, I was always clear as a rehabilitation nurse, in working with therapists, is they didn't just say that a patient has a balance problem or a gait problem and start implementing interventions without knowing what's the pathology behind it, doing more in-depth assessment. But for some reason, nursing just did not do that. As I reflect on it, I kind of think it came back to around 2007 when the Joint Commission finally added falls to a patient safety adverse event. And an indicator for performance measures within hospitals. And it was a Joint Commission then that said hospitals will have a fall prevention program for nursing and will do assessment. And I think that that's really when organizations made a commitment to bring a tool on board, but they didn't really understand the background of a tool, the validity of the tool, the purpose of the tool, and they just put that tool out there as if it was an assessment tool. So it's been so difficult, don't you think, to be able to get organizations to change this and get back to appreciating that screening is not assessment?
I do, and I think part of it is, it goes back to how how people consume the literature, right? You have to read the entire article. You can't just read the abstract. You really need to seek to understand. And if you don't, contact the author. Understand that just because it's published doesn't mean it's good science. You and I have seen that many times over. And I think that for the most part, really, until you get into your master's programs these days, you really don't get good recommendations or acumen around consuming the published literature, right? And so if you think about how many, just bachelor's and associate degree and even diploma prepared nurses that are out there, those people were in leadership positions. It wasn't until we had magnet drivers and things like that that really started pushing advanced education and nursing leadership, where people really understood what evidence-based practice meant, what it meant to consume the literature. And we have these sacred cows in nursing that continue to perpetuate, and they're really hard to de-anchor and get out of the way. So I think that's probably the etiology of it. I think we're better at it today than what we used to be, but I think back then that was just part of what was perpetuating the misuse of so many tools.
I absolutely agree with that. So we have so much work to do, even in 2022, and the expectation is that all organizations, all nursing practice is evidence-based. So, the example that I always give to organizations too, and talking with nurses throughout the country as you do, is there's such a simple example of screening versus assessment. When you think about the public health model, a positive screen was always to differentiate who needs to have further workup. That's the public health model. And if you think about a diabetic patient, and we're taking care of diabetic patients, my staff nurse on a unit, you just don't ask someone if they're diabetic, yes or no, and they say yes, and you start treating them right away. It's the very same thing with all of the risk factors that a patient can have. By relying on just these screening tools, they miss the whole picture of all the risk factors that a patient can have when they're at risk for falls. In running so many falls clinics in the VA, we would work up patients in our clinic that would have 14, 15 fall risk factors. If you relied on the Moore scale, you'd never get there. I know your program, and I hope that you can share with our entire audience who's listening to this about how successful your HD nursing tool has been in shifting from screening to assessment.
Way back in 2006 and 2008, when we really figured out that we didn't have the tools necessary to be successful in preventing falls in our patient population, the foundation of that was understanding risk, right? And understanding risk better in a population that almost ubiquitously has some degree of risk, right? In a neuro population, there's functional deficits in almost every neurodiagnostic category, right? So how do you split that up? How do you take care of a right brain versus a left brain CVA differently? How do you get to the root of what it is that's creating the issue for that individual patient? So we knew that we needed an assessment tool versus a screening tool. We knew that we needed to design that. And so we did, but we quickly learned that the assessment tool is just a compass that points you to which patients need your care. The real magic of falls and injury prevention happens in care planning. And care planning is so much more of a complex process than what people give it credit for. We hear care plans day in and day out, and that's the whole core of the nursing process: assess, plan, implement, and evaluate. But we don't really give credit to all of the complexities that are folded into that. And so we really began figuring out that you needed a compass, but then you also needed a roadmap that was going to, take you on your journey for that individual patient. And so the prediction tool that we have is much more sensitive than other tools that are out there. We did validate it on paper and within an EHR. We were the first people to actually do that. We didn't realize we were the first people to do that until after we published, but it turned out that we were the first people to ever take any prediction instrument and validate it both electronically and on paper. And we proved that it was a stable instrument, regardless of how it was used, had a very high sensitivity, and it correctly identified the people that were at risk, and it gave clinicians the information that they needed to know to individualize their plans of care.
And you have been so successful, and you are absolutely to be congratulated with your commitment to really move care planning and practice further for every single nurse in every place that we take care of patients. So indeed, congratulations. And with that, all the patients that you're saving because you're mitigating and eliminating their fall risk factors, which is what should be the measure of success when you can get to that individualized care planning. But Amy, why do you think hospitals are so slow to understand that screening is not the same as assessment, and why we can't seem to get those changes made to integrate assessment tools into these hospitals, into practice?
I think part of it is just we get comfortable with doing things the way that we've always done things. And it's hard to break people out of that rut. It's really hard to get people to be open-minded. And I think part of the issue that I've observed is to really be open-minded to a change in practice means that you have to be comfortable with the thought that the way you've been doing things for so long may not be the best way. And that's tough to, that's a little sour, right? That leaves a little sting. And so I think some people emotionally protect themselves and think the way I'm doing it is the best way that I can serve my patients today. I don't need to look at anything else, because if they did look at something else, it would be an admission that maybe they haven't been doing things the best like they thought they had been all along. We've had lots of conversations about that with different colleagues, and we've gotten feedback about that it takes a lot of emotional intelligence in a leader to be open-minded, to realize that maybe things aren't the way you thought they were all along, and there may be a better or different or more unique way or more effective way to engage in patient care.
Well, I so agree with that. And I also think that hospitals really drag their feet when it's time to update those templates, to change from screening tools to move into to a tool that has the actual assessment of risk factors and care planning means that they have to go all the way back and start, actually redoing what they're doing. They have to change their policies and procedures. They have to change their electronic medical record templates. I mean, it's a whole new initiative that they have to launch that involves so many of their departments within an organization. Isn't that true?
You're absolutely right about that. And I would say that even people that are open-minded to that look at all of those things that you just said and think, oh my gosh, I can't do that by myself, or oh my gosh, that's really hard, or oh my gosh, there's so many other things that I need to do just as normal routine parts of my day. How will I ever fit that type of work into my day? And that's exactly why we built a program around the tool that we developed, the care plans that we developed. We developed an implementation plan, a project plan, and a sustainability plan so that organizations didn't have to do that. We took all of that burden off of them. We need a project leader there that's going to get us to the right people that we need. But when you think about it, so, some systems have over 10,000 nurses to train. So when you just think about that, oh my gosh, and I've got a union to deal with. Oh my gosh, how am I going to deal with that? So, that can be really scary. So when you take all of those barriers down and that scariness away, I think it makes change easier.
Yeah, absolutely. And it starts from all that strategic planning and keeping on top of it to see how is it launching and making sure that there's success. And when there's not, how do we step back and look at where the gaps are and continue to go forward?
That's right. That's exactly right. In a data-driven way. In a data-driven way. And that's key. Having the data to inform your decisions so that you're not doing things anecdotally. You're really letting the data tell the story and point you in the direction to what your next most valuable action is.
Yes. And I think too, organizations are really reluctant to really focus on truly evaluating whether or not structures and processes are actually working. They focus on the outcome, for example, a fall rate, but they're not really making sure that their assessment tool, what they call assessment, or their care plan is actually working. That it's getting done, it's making a difference at the point of care, it's actually being implemented, following through how patients are responding to care planning. It's the structures and the processes that I think there's just not attention on that.
That's right. And I think, those are process measures that you're talking about. If you think of Donna Bedian's model of quality, that's all process measures that lead us to those outcome measures. And so That's part of what you have to think about. And that's exactly what we've cultivated into what we do, is measuring all of those process measures that lead to your outcome measures, and your what I will say in the end is your measure of success, right? Did you prevent falls? Did you prevent falls with injury? All of that has to be there. And I think, you bring up a good point about quality assurance and quality improvement. There's a lot of folks out there that just don't even know the difference between those two things, right?
Mm-hmm.
What is quality assurance versus quality improvement, and how do they, in a life cycle, really, it's a cyclical relationship. How does that work together? And so, what's really encouraging to me about that, and what I love about DNP programs, is they're putting out nurses, DNPs, that really understand that, like we haven't understood that before. And so we're getting DNPs into practice now that are going to help us bridge that gap and connect the dots for undergraduate nurses, or for maybe leadership that needs to be brought along a little bit differently. And so nursing is lifelong learning. It's you can't just stop. You can't just get that degree and think, okay, I've got this. It's lifelong learning. And I think a lot of people pay attention to clinical skills, but there's also all of those other quality and risk pieces that come along with that paint the full picture.
Yeah, thank you, Amy. And for those of you who don't know what a DNP is, that's the doctorate in nursing practice. It's a clinical doctorate, like an MD, a medical doctorate. So yeah, thank you for really validating the importance of that role within all of nursing practice. I so agree with you. We have so much opportunity to really look at structures and processes. As a rehabilitation nurse, my goal was always to help improve knowledge, skills, and abilities. So and if someone did fall in my care, I would always say that and I still do, that I would rather someone fall in my care and learn about it, but I want to make sure that when they're discharged, they've got the knowledge and the skills to be able to prevent falls, to be able to, if they do fall, be able to handle it and manage it with confidence. So I think there's just so much opportunity for us to truly look at whether or not structures and processes are working. So what do you think, Amy, are maybe the top 2 or 3 strategies to really motivate hospitals to compel to change?
One strategy is not being satisfied with the status quo. Just because you outperform a benchmark doesn't mean you still don't have opportunity to get better, or to continue to improve more lives or save more lives through fall and injury prevention. There are lots of folks out there who look to the benchmark, and if they outperform that, then they don't think falls is a problem for them. They should always look at all of their quality indicators as an opportunity. Always keep going outside the box to make their quality indicators better and to keep improving. And I would say, secondly to that, is make sure that you have people in leadership positions that understand these concepts that we're talking about today, that understand evidence-based practice, that understand quality assurance, that understand quality improvement. And that if you don't have the right people in the right role to motivate and support change, you may need to rethink your positions. And I understand that there's people that have been there for a long time, but you may need to create a position that's going to foster and facilitate that within the organization. And you need to empower those positions. Those aren't just positions to be positions. They need to be positions that are empowered and have the authority to make change within an organization. So many people that are change agents within an organization, they just aren't empowered. They have no authority to make the change themselves. And so they're at the mercy of other people in their organization.
Yes, I so agree. And a couple of the strategies that I would like to add too, to share with our audience, is that a lot of times when people come to me to help with their fall prevention program, and I know to you as well, is because they start seeing their fall rate going up, and they start, knowing that that's going to be affecting their performance measures, their benchmarking, where they stand in relationship to magnet programs or other programs of excellence, but they see that their fall rates are going up. And when we actually end up having an opportunity to talk with organizations, I know that you and I are always confirming to them that what they're doing right now isn't working. So, when they learn that truly things are not working, patients are continuing to fall, and they're getting injured, or they're having loss of life, that they know they have to do something different. So I think that does help them to change, but we also are committed to making sure that they know that they have the resources to be able to do that. I think another reason that compels hospitals and motivates them to change is litigation. It is one of those, if you will, unspoken costs of falls that occurs that few people actually talk about. But you and I know that there's a huge incentive when there's that whole litigation aspect of it. Would you agree?
I definitely agree. And that was true for me in my own journey. My colleague Dees Davis and I, we didn't mean to cure the ills of the world for falls prevention. We were really looking to we were solving the problems of our 30-bed neuro unit. And so, but it turned out, and at that time, we didn't share data. You didn't ask to see another unit's data. That was taboo back then. And so we had a really nasty fall event on our ortho unit. And that gentleman died 3 days later of a head bleed. He was only 48 years old. And that resulted in a lawsuit that our organization, it was a very public lawsuit. It was on the front page of the local news quite often. And we paid a very large settlement on that, which really, that was a catalyst for Dees and I realizing, well, gosh, maybe it's not just our neuro patients that have a problem. Maybe there's other populations that could benefit from the work that we've accomplished. And so we went to administration and said, look, what do other people's data look like? We crossed the line in the sand and said, we're going to do it. And we did it. They opened the book, and it was tragic. It turned out that our organization was the next to worst in the nation in our national benchmark comparison for falls with injury. So as it turned out, as we deployed our program across the rest of the house and validated it in other populations, it was a great solution for them too. But the catalyst was a sentinel event alert that landed in litigation.
I know, and I know that many people who are listening to this can really relate. So, when we talk to people and we get to help organizations confirm that what they're doing is not working, there is preventable loss, there's preventable suffering, then I think that is a motivating factor. But at the same time, I know we together are committed to motivating people because there is the other side of the equation. Those who indeed are not falling in our care, but they can learn more, and be more independent and have more confidence. And that's really so much of the essence of what we do as well, isn't it? Because nobody wants someone to fall in their care, but they really don't. Everybody wants to have a safe organization.
That's right.
And I also think another incentive, Amy, that we're very committed to is that return on investment. When we're actually able to show organizations, which you are so successful at doing, that if you change practices, if you change workflow, you can really save money. You can reduce the burden of care for the nursing staff. There's so much in terms of a return on investment for change.
Yep, that's right. And there are lots of buckets of costs that people don't always factor in. I think people think to litigation. They don't know how much litigation costs, but they know there's litigation issues that are there, right? And so those numbers are there. They're in your risk management office. Your risk manager knows exactly how much they're spending on average for fall-related claims. But there's the medical cost. As hospital-acquired conditions, fall care is not reimbursed by Medicare or other insurance agencies. But another really interesting bucket is workers' comp. So the workers' comp injuries can be very expensive. The average claim for a workers' comp injury that happens when a staff member is rescuing a patient off the floor after a fall is over $20,000. It's actually close to $30,000. And so, and then now you've put one of your healthcare, workers out, on workers' comp, and good Lord knows we can't afford that these days with all of the staffing crises that are happening. So there's a lot of costs associated with falls.
Yeah, absolutely.
Even falls that don't result in injury cost money. It increases length of stay. There's imaging. There's all sorts of, it changes people's disposition on discharge. So all falls matter.
Absolutely. And all risks matter. So if we can actually help patients reduce their risk while they're in our care, prevent those falls, then we can save their function and independence after they leave us. Because it's still relatively rare for falls to happen in hospitals with all the staff around them. I mean, 60% of the falls happen at home, 30% in the community, only 10% in our care. So we have that moral imperative that you and I share to make sure that we do all that we can to create as safe as an environment as possible to be able to reduce those risks and those costs, the burden. So, Amy, what do you see on the horizon for fall prevention?
So that's a good question. I think there's some work being done in EHRs to build cognitive computing models and AI that runs in the background to inform the nurse about patients that are at risk. There's pros and cons to those. There's new technology. We definitely have new advancements in technology that are coming out and refinements of existing technology that have been long overdue, I would say, to be more nurse friendly, more user friendly, more integratable. I think that's one thing that Curbell does exceptionally well is integration. And that's something that we actually see when we go into organizations and do that gap analysis on the front end of implementing our clinical content is that a lot of people are not integrating the resources that they have. So I think interoperability and integration is it's not necessarily something new, but I think it's definitely something that people are more aware of in the context of interoperability doesn't just mean do your EHRs talk to each other or can you translate data to other places. Interoperability is really, is this piece of equipment going to work with my call out system? And is that going to push to my nurse communication system? So I think interoperability has been there. I think nursing administrators and quality directors and even risk managers are just now coming to grasp the concept of how important interoperability is when it comes to material resources and driving the right care to the right patient at the right time.
Yes, I see those too in the horizon. And I'm also so optimistic, especially with the work that you're doing, that we move to population-based fall prevention. Treating everybody as if they're the same, we're over it. It just doesn't work. I am so optimistic of doing something different for my 85-year-olds who come into anyone's care because if they fall, they die. It's the number one leading cause of unintentional injury death is my patients over the age of 85. That's who I embrace. I know you do too, as does Curbell Medical. But we have to protect them in a different way, no matter where they are. So that's what I so hope in our future to be able to do more in terms of population-based approach to fall prevention. How we take care of people with Parkinson's disease is different than people with dementia. And then I also want us to reduce the silos of care. If a patient has a fall prevention program that's working in long-term care and they end up in our hospital, that safety net should follow them. It shouldn't be setting specific. That we have more that we're doing for continuum of care is what I hope for our future, so that we reduce those silos of care. So those are like my two hopes as we go forward, and as well as continuing to integrate technology. Because fall prevention, nurses can't do it all. We have to have technology that we can use that complements our workflow, that complements our practice, that helps us. Realizing that, we're in 2022, here we are with a greater shortage than ever, a nursing workforce shortage, but also the loss of our seasoned expert nurses, relying on a lot of traveling nurses and novice nurses. So how can we get them up to speed as well? So integrating technology, I think that can help that. But moving into population-based care, reducing the silos, making sure that someone's, especially their injury plan of care, is not setting specific, but patient specific.
Yep, I agree. And that goes back to how do we communicate in transitions of care? And how do we get people to use material resources across the continuum, including the home environment? How do you get some of the resources that we have in the hospital and in long-term care and transition them in a meaningful way to the home environment to keep them aging in place as long as possible? People haven't always had those assets that we have in the hospital when they go home, right? We have all these great material resources, but they don't follow the patient. And then all of a sudden we wonder why there's so many 30-day readmissions. And falls is the most common cause for contributor for readmissions within a 30-day period. So if you're in value-based purchasing, that really means a lot. And almost all of us are in value-based purchasing models. So it's definitely something to think about.
Well, Amy, I just can't thank you enough. We know that the great work that you're doing, Amy, had its origins, but you have exceeded all expectations in the work that you're doing and saving lives and launching programs throughout this great country and beyond. Your mission and your vision is absolutely palpable. Your commitment and your energy as you go forward is extraordinary. That sets you apart as an entrepreneur, a nurse scientist, a nurse informaticist, as a doctorally prepared nurse. We can't thank you enough for spending this amount of time with me to be able to share with people your ideas, your vision, your work, and what you hope to see in the horizon above as we go forward. So thank you, thank you, thank you. And with that, is there anything else that you'd like to say in terms of closing remarks to the world as they listen to us?
Thank you. Stay open, keep learning. Don't be afraid to innovate. Nurses are some of the best innovators on the planet. So, and you don't have to have a doctorate degree to do that. I started my journey when I was bachelor's prepared. So, to give yourself credit. Nurses don't give themselves enough credit, and tend to be very altruistic people. So make sure that you give yourself credit, be that lifelong learner, and be that patient advocate.
Thank you. And colleagues, to all of you who have been listening to this podcast, thank you for joining us, and stay tuned for our following podcast. Thank you again, Dr. Amy Hester, our first featured guest. Thank you so much, Dr. Hester.
Thank you for listening to the Care Team Conversation podcast, sponsored by Curbell Medical. A special thanks to our guest, Dr. Amy Hester. We greatly appreciated you sharing your expert knowledge on the evidence-based approach to patient fall prevention. Thanks to our wonderful host and patient safety expert, Dr. Patricia Quigley. For more information about HD nursing and the Hester Davis Fall Risk Scale, please visit hdnursing.com. For more information about Curbell Medical and our innovative products, please visit curbellmedical.com. You will be able to find this and future podcasts on the Curbell Medical website or wherever you listen to your favorite shows.